Position of the gum. Yep, we want to know where our ET tube is. Perfect. What else?
Setting, I guess respiratory settings.
We want to check our respiratory settings. Yeah. We want to know the size of the tube. I heard. What else?
Make sure it's not like kinks or in like the proper position.
Yep.
Suction setup.
Yep, an extra suction setup. So how many do we need if we have an intubated baby? Two, right? One for oral suction and one for inline suction. Perfect. Okay, what else?
The card where everyone knows everything.
Oh,
the bundle, whatever.
Yeah,
card.
so for your safe suction depth, size of your tube, yeah. So I've actually heard 50-50 on this. We're trying to move away from those cards because we found that sometimes they're not updated as frequently as they should be. So just always, we'll talk about this, but doing your due diligence of like double checking all of that information. You know, if it says to suction to double yellow, making sure that you're actually like measuring that out and doing it for your first time on your shift. But yeah, perfect. One other thing, what if we think like emergency scenario, we're worried the tube is not in the right place, what else? CO2 detector, right? So this guy here, this should live like right near your vent, easily accessible, able to grab, you know, at a moment's notice. What does this guy do for us? Detect CO2, yep, just what it says. So this one has been used. They look like this. They hook right onto, if I would have needed to bag this baby, I could disconnect my vent, connect my CO2 detector, and then bag straight through this. And this little window right here that is already yellow would turn yellow. So it starts as a light blue. It would turn yellow on exhalation if it's detecting CO2, okay? So I want to make sure that these are at the bedside so that you can grab them. We had a couple of people ask, has anybody heard about like airway boxes or like a second ET tube at the bedside, anything like that? So we don't do airway boxes anymore, but thinking about those emergency situations, we want to make sure that we know how to access another ET tube if we were to need to reintubate this baby, right? So our airway carts in every neighborhood are what took place of those airway boxes, okay? So if you have a baby, if they're intubated, you're hitting that inset button or you're calling out for help, more often than not, at least somebody is grabbing the airway cart at baseline and maybe the code cart too, okay? Because all of those things are going to be in there for you guys, okay? Okay, I heard somebody say we want to know where it's at the gum, right? Why the gum? Why is that our anatomical marker? Rather than like the lip, the tongue.
Anatomic differences. Right?
Yeah,
Oh,
yeah.
sometimes they move.
Yeah, they can swell, they can be different shapes, sizes, things like that. So it's just like a stationary anatomical marking that we can use as a baseline to know where we're at. So part of your safety checks when you come in, if you hear, you know, I have a 3-0 at 5 at the gum, you want to make sure that you're getting in and making sure that you're checking that, right? That doesn't mean that you need to come in and totally unwrap this baby before their care times are due, things like that. But you will see. So you guys can see these numbers on this tube on the underside right here. So if I couldn't, you know, definitively see, okay, 5 at the gum without like really getting in this baby's, like all up in this baby's stuff, I could find this closest number that I can see that that's a 10, and I could pull out like the same tape measures that we use for birth. You could just grab a new one. These go in cm, so you could measure down to the gum, so that way you can see more clearly. And mark that if you can't get like a good visual of that number on here. If you can see it, that's great. Turning on the lights, pulling this up, you know, kind of pulling this down. If you need a suction, you can kind of do that if you want to get a good view of that number, okay? Okay, so we want to always check that. We want to check our suction. What should our suction settings be for inline suction? 80 to 100? Yeah, so 80 to 100, yep, as well. Perfect, so make sure that those are correct, make sure that everything's connected. Somebody said vent settings too, right? We want to check our respiratory settings, wonderful, perfect. Okay, let's talk about infection prevention when it comes to these kiddos. So let's talk about suctioning first, oral suctioning, deep suctioning, and then inline suctioning. When do we oral suction these babies? Yeah, after their oral care. How often do we do oral care? Every care, right? So we want to minimize that bacteria growth, make sure we're keeping these babies' mouths nice and clean, we're not hiding any gunk in there, or as needed. Why is it so important to make sure that we're not just like building up oral secretions here?
So the tube doesn't
Yeah, so what is our securement method for these tubes? This baby, nothing sticks to her face, so she's got a tape head here.
Tape for the arch.
Yeah, so the neo bars are standard for like our smaller babies, and then sometimes our term babies that are intubated, you guys will see, we call it like the PICU way of taping. which is really just that like silk tape that goes across the face. So not so much will you see with oral secretions that these come up. A lot of the times it's with like movement that these will start to peel. But this tape around the tube and the top of this here, that is where oral secretions is going to like mess up that integrity of that tape, right? So we don't want this to be able to like easily slide in and out of this tape by any means. Okay, so that's great. We want to make sure that we're keeping our mouth nice and clear. What about deep suctioning? How often are we deep suctioning these kiddos? So that's with these guys.
That's only one indicator.
Not as needed. So there is a standard. Could do it more regularly if they, you know, have extra secretions. But what's our standard? Has anybody told you that? Take a guess. What do we think?
Once a shift.
Once a shift. Yep. So once a shift, we want to make sure that we're deep suctioning at least. Really for any of our like high respiratory babies. So think like high levels of bubble CPAP, NAVA, any intubated patients, if they're on MIPIV, things like that. Thinking about, you know, these oral neosuckers. Where is the neosucker? This plastic is incredibly rigid, so we're not going to go like all the way to the back of the baby's throat with this because that would like hurt and irritate their mucous membranes. So we can use these deep suction catheters to get where, you know, these don't go and before we get to like the bottom of the ET tube.
Are the purple less rigid? I haven't
The
touched
purple.
The purple
Of these?
suckers.
They should be about the same plastic. Yeah, so they're pretty rigid. So these will be the ones that will go down a little bit deeper. It'll just kind of get that stuff that's really sitting like deep in the bottom, in the back of their throat. Because if we don't do anything with that, it's just going to sit there, it's going to harbor bacteria, and then eventually it will migrate down into the lungs, and it's going to cause like all kinds of issues for these babies. So at least once a shift. And then what about inline suctioning? How often are we inline suctioning? With cares, yeah, if they're desatting, things like that. Why do you guys think we do with cares? Like, what's the reasoning that we do? Yeah, so a lot of these times these babies are like Q-based cares, right? So we may go like 5-6 hours without touching them. So if they're laying, you know, on their side or prone for that long, junk is gonna build up, and then as soon as we move them, it's all gonna kind of dislodge, and then again cause those issues for these kids. So a lot of the times you'll see that we'll suction before we move them. And then sometimes even, you know, after we do their cares, we'll suction them before we move them again, just so that we're clearing everything out.
But we cannot do it before getting a gas.
It depends on what the baby needs. So if the baby, it's not like a hard and fast, you cannot do it if your baby's desatting and not doing well. I don't think there's like a hard and fast rule on that. Yeah. With inline suctioning, if you have a baby that has like PPHN, is really sensitive to suctioning, if they have a history of pulmonary hemorrhage, those may be reasons to like limit the amount of suctioning. So those may be the kids that you don't see that you're suctioning every single care, or every time that you move them, but always kind of like go to the baby's cues, okay? With suctioning, so we talked about that suction card, the ET tube card. Did anybody say anything about the colors or the numbers? Like how are you measuring your suction depth?
Don't you line up the mouse and
Yeah, so you're gonna line up the numbers. So I have a little disconnected ET tube and suction catheter here. So you guys may hear people like leave and be like, oh, my baby suctions to red or my baby suctions to blue. That is a nice marker if there's an emergency and you don't like have time to like flip this baby over, look for the numbers, line everything up really methodically. You can just very easily be like, all right, I gotta get to blue, and there I am, and then I can suction back. When you're coming in, like I said though, doing that due diligence, double checking everything, when you're coming in for your first shift, we want you guys lining up these numbers. So you'll see that there are numbers on the actual ET tube, and then there are numbers on your suction catheter, right? So when you start feeding this into your ET tube, you will see, so right now I'm at 7 on my suction catheter, 14 on my ET tube. So you're gonna keep going until you get 14 and 14. There's my 14, there's my 14. And you'll see when those numbers overlap, that suction catheter is right at the end there of that tube, okay? So we never want to suction past that because then we can do damage to that, the bronchioles. Where that number comes from is we're looking in this little window right here. So this baby's like right in between double blue and double yellow. So you guys may hear, again, people say that should really only be used in an emergency. If you get that in report, you shouldn't be like, all right, that's my end all be all, that's what I'm doing all shift, and I'm not gonna double check it. You should always do your measuring. And if you guys saw when I was lining up these numbers, you can pick any number, it doesn't have to be 14. Any number that coincides, so when I line up these 14s, you can see 14 and 14, 13 and 13, 12 and 12. So no matter what number I pick to overlap, all of them are going to be overlapping with the same number, okay? Makes sense? When you pull this sheath out, this little button here is what's going to activate that suction. So the entire time that you're pulling back, you want to be holding this down so that we're pulling anything that's in that tube out, okay? What about after we suction? Do we just leave all of that gunk in the catheter? Yeah, so we use saline bullet, right? So they look like this, saline bullets. How often are we doing this? Thank you. Every time that we suction, yeah, because we want to clear out that tube. They look like this. They've just got like a little twist top. I always recommend coming in with an alcohol. You would take your alcohol, pop that top off. When you come in here, I like to take this off with my alcohol off my port here, and then connect my bullet. When I go to clear this line, again, I'm going to be holding this down the entire time, because if I were to just squirt this in, it's going to go right down that baby's tube and then cause a world of issues for her. So as I'm squirting this, I'm going to hold this down so that it's actively being pulled right out, and it's going to clear that line. I'm going to disconnect, alcohol again, and then close that port. Always make sure you're completely closing that port so that we don't have any air leaks, okay? So that's everything with suctioning. We talked about oral care. Let's see, what else do we want to talk about?
I think for the gas question, it's usually like 5 to 10 minutes. Like as long as you haven't suctioned within it's a very short time frame.
Okay.
It shouldn't affect the gas. Okay. I've heard some people say 30, but like evidence-based wise, like 30 minutes is like way too, and we have babies, like Jordan said, you should suction your baby if they need it. Yes. But it's usually if it's in like the 5 to 10 minute range that sometimes we see like some altered results, but as long as you're outside of that, you should be fine. I would just tell your RT, this was the last time I suctioned, and they'll let you know, like, let's maybe give them a little, especially if it was like a bad DSAT, like how bad the event was, like maybe we do need to give them a little bit more time to just recover.
Okay, let's talk about x-raying these babies. So let's say it is 5 a.m. Our x-ray tech has come in for an x-ray. What are we going to do for this baby? Turn them, right? How are we going to turn them? How do we want them positioned?
On their back.
On their back? What else?
Their legs. Yeah. And their arms are out of the way of the chest.
Yeah. So, and then that might all differ too. If we have PIC lines and we want to see PIC placement, you have to position their legs, arms a certain way. So what about pillows? Can we keep pillows in here? Pillows out?
Pillows out.
Mm-hmm. How should the head of the bed be? Flat. Perfect. So supine, we want babies midline, we don't want their heads turned, we don't want their bodies twisted, things like that. So let's talk about, will you be my second set of hands since you're over there? We should always be moving babies, doing cares that are intubated with a second set of hands, right? So if we have our x-ray tech in here, we need to get this baby supine. So let's untuck her. Okay. So you guys will see, you'll learn what your flow is, what other nurses' flows are when they are moving intubated patients. One thing that I always recommend is that whoever is on the side of the circuit and the ET tube should be in charge of the tube, and that should be their only job, okay? So when I'm coming in here, if we want to turn this baby onto her back, since the tubing is over here, I would be in charge of that tube, okay? So I'm going to hold the tube, and I'm going to have you turn her. Okay, perfect. Turn onto her back. Beautiful. Tape headgear here, perfect. Okay, so now could we x-ray her like this? What do we think? What do we want to do? Arms down. So her arms don't really go down. Yeah. But yeah, so we want her perfectly midline. We could move her head a little bit, make sure her body's not twisted. Perfect. And then we could just rest this guy here. Now, if I were to say, okay, she looks great, x-ray tech's here, and I walk out of the room, is she going to stay like this? Probably not, right? So, yeah.
Cylinder blanket.
Yeah. So you can make little like blanket rolls for them and try to, do like contained tucking, things like that. You can use these guys to tuck over them. Truthfully, one big thing that I feel like our unit is trying to get like better with x-rays is that we don't want to expose these babies to too much radiation. And even if we do this tucking, a lot of our babies are still strong enough that they can like move their arms, they can move their head. They don't like being on their backs by any means, especially not if you've just woken them up from like being on their belly and they were all nice and comfy. So yeah, the x-ray techs, they keep lead with them, the bodysuits and then the neck guards as well. So if you guys are not comfortable, talk to your charge nurse, talk to RT. Somebody really should be staying in here with these babies to hold them in place so that we're not having to shoot multiple x-rays on these kiddos, and we can just get it in like a one-stop shop. Okay? Alright, so let's say we got our x-ray, we're all good with that, we got her in a nice supine midline position, and now we want to tuck her back in on your side. We're going to have her facing you on her belly.
So
Okay?
we have the tube then.
Yeah, so the first thing that I would say is let's move the circuit over to you.
Okay.
So I'm going to hold on to the tube so that you can bring the circuit to you. Okay, perfect.
Maybe like move this or something.
Yeah, so a nice little trick. Yep, perfect. Anytime that you're moving this tube, it's going to kink. The tubing should always twist towards baby, and that will happen. That's why I have the tube, so you could feel some of that manipulation. When you're moving the circuit, somebody else should always have a hand on the tube, so that way whatever she needs to do over there to get that tubing settled in the right position, tubing isn't kinked, we're not worried about it pulling out of here, because this will inevitably, pull a little bit on the baby's tube. Okay? Perfect. Okay, now that tubing is on your side, so now you're going to be in charge of the tube for us putting her on her belly. Okay, so I'm going to let go. She's nice and calm. Okay, so I would actually hold tube with this hand, and then you can hold circuit with this hand. Okay. So anytime that we're turning baby, we're going to go in nice slow steps. So we're going to kind of turn her as one little entity. So we're going to turn her onto her side first. So I'm going to say 1, 2, 3. Turn her onto her side. Get her nice and comfortable. I can fix her legs however I need them. And then your job is pretty, you're not really going to move a whole lot more because this is where her head is going to be at the end. Okay. I'm just going to lift her up to get her hand underneath of her so that we can put her on her belly. But when I say I'm going to go 1, 2, 3, we'll just lift her up. And then I'm able, again, I'm not moving her head at all. I'm just moving her torso and pulling her arm out so that she's nice and comfortable. Her arms don't really cooperate. But then I can tuck her little legs in, get her in the snuggly, like so, get her lines out. And then once she was settled, and again, her head's gonna move a little bit because she doesn't really move like side to side, but then we could tuck her in nice and easy like that, and she's good to go, okay?
Is it okay for this to be like downward, or does it have to be like?
You don't, so if she was lying flat, ideally she'd be on a pillow.
Okay.
So she would be elevated a little bit and this wouldn't be so downward. But if she was flat like this, I would take this guy out.
Okay.
Because these will get condensation in them because they're humidified. So you never want it to be kind of like draining down into her, because then it's gonna build up in her lungs. Okay? Yeah, great question. Okay? Any questions?